Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm joined by Dr. Luke Sayers, a GP partner and the lead for clinical continuity of care at North Tyneside Integrated Care Board, and Dr. Tom Kennedy, a GP registrar and ICB clinical fellow, to talk about the importance of continuity of care. Coming up, Luke and Tom explain why continuity of care is so vital for both patients and doctors, discussing the evidence that shows improves patient safety and reduces mortality, as well as the positive impact it has on GP job satisfaction and retention. We discuss the misconception that focusing on continuity negatively impacts access, and they explain why the reverse is often true. They also set out practical steps practices can take to improve and measure continuity, including the use of micro teams and personal lists, and how this way of working fits into the vision of a neighbourhood NHS. This episode of Talking General Practice has been supported by Dexcom. Season 2 of Dexcom's podcast Diabetes Dialogues is here, and they'll be discussing type 2 diabetes. New voices, fresh insights and real conversations you won't want to miss. If you haven't heard of Dexcom, they've been developing continuous glucose monitoring systems for over 25 years, empowering people living with diabetes to make informed decisions and improve their glycemic outcomes, and Dexcom has more level 1 evidence than any other CGM brand. This season, Dexcom will be tackling the topics that matter most, inviting expert healthcare professionals to share fresh perspectives, challenge conventional thinking, and open up meaningful conversations about how we care for people living with type 2 diabetes. You'll hear from GP Dr. Jackie Elliott, GP Dr. Sarah Davis, Professor Sam Saidu and Dr. Wakas Tahir on the future of type 2 diabetes, the role of the GP in management of type 2 diabetes with Dr. Sarah Davis, plus episodes on health economics, technology and approaches to management of type 2 diabetes and more. Season 2 is now streaming, so tune in, subscribe on Spotify, Apple Podcasts or wherever you listen, and be part of the conversation about changing type 2 diabetes care. Dexcom's Diabetes Dialogues podcast has been created and fully funded by Dexcom UK and Ireland and is intended for healthcare professionals practicing in the United Kingdom and Ireland. I'm really pleased to be joined on the podcast now by Dr. Luke Sayers and Dr. Tom Kennedy. Luke is a GP partner in North Tyneside and the lead for clinical continuity of care at North Tyneside ICB, and Tom is a GP registrar and an ICB clinical fellow. Thank you both for coming on the podcast.
Thanks for having us.
Yeah, thank you.
We're here today to talk about continuity of care. I mean, Luke, you're the lead for clinical continuity of care in North Tyneside. What exactly does that role involve?
So it's a bit of a mixed role. So I've been doing the role for the last 2 years alongside my clinical work in North Tyneside as a primary care GP partner. So I've been a partner for the last 13 years in a personal list practice where we see 8 out of 10 patients ourselves. The last 2 years I've done a session a week looking at continuity. So it's been looking at the benefits of it, looking about how you encourage it, and just thinking about how we could do it in people's contexts. How we do it in Whitley Bay for our patients is quite different to how others do it. Part of it has been chatting to other practices around the country to see about their models of continuity, which has been really interesting because most GPs don't know very much about continuity. It's kind of disappeared. Over the last 2 years, I've chatted to 18 practices around the country about how they deliver good levels of continuity. Some of them use micro teams, some of them use salaried GPs and partners, some of them have buddy systems. Most of the GPs work part-time, so they make that work really well. And they all have different populations, so people will have deep end practices, rural practices, but they'll use continuity as a tool to make it work for them. So I've been able to see there's loads of different ways of delivering the same thing in different contexts. I guess it's given me some takeaways, which probably want to pass on, which is the key takeaways is there isn't a blueprint to continuity. There isn't something we can just badge and say, do it this way. It has to be built bottom up from practice's own populations, what clinicians they have, what's in their team. So that's the bottom up approach is key. Also, practice culture is key. So building it into your culture is key. So over the last 2 years, we've got 3 pilot practices involved. Those practices cover about 46,000 patients in North Tyneside. So that's quite a large number of patients that are benefiting. Our role now is to support those pilots and see the outcomes over the next 18 to 24 months. Now it's trying to really embed continuity in GP culture, in policy. The key thing is showing it's possible, because most people go, well, continuity, that's a nice thing, but you can't do it in model general practice. And actually, you really can. And it doesn't have to be our way. It can be 18 other ways I've seen of doing it, all getting really good outcomes. So that's what we're doing at the moment.
Tom, how is it that you became involved in this work as well? What are you doing around this area?
So I, through my general practice training, took some time out to work on kind of leadership and supporting various projects, particularly in North Tyneside, which is the area kind of immediately east of Newcastle out to the coast. Whilst I was doing that post, I came to meet Luke, who has been working in a really high continuity practice for years and years and has been kind of banging the drum for kind of continuity across the Northeast. And we were supported really by a programme run by the primary care team at the Integrated Care Board, who were looking into ways to basically improve access and improve the quality of access to general practice across the patch. And so they had gone out to various providers working locally, various stakeholders and patients to identify what are those priorities. So lots of the kind of common themes came up that you might expect, things like refining patient pathways and thinking about new ways of doing things like remote monitoring. But continuity of care was something that came up repeatedly as well. Lots and lots of positive feedback. Joe Wood, who is the head of primary care in Northumberland and North Tyneside, is kind of coordinating the project, characterises continuity as kind of pushing at lots of open doors or knocking at lots of open doors. And that's really what we found, is that instinctively lots of clinicians, lots of patients know that this is something that's really important.
Luke, your role is a clinical continuity of care lead for your ICB. I mean, is that a common role in ICBs, or is this something that's quite innovative in your area?
I think this is the first ICB in the country that's invested in continuity. They've got some national contacts and they've never heard of another ICB doing this. And we were at the Royal College of GPs conference in Newport. Yeah, it's not something that is thought about very much at a policy level. So investing in it as an ICB is really forward thinking.
How did you both become really interested in this? Because obviously something you both feel really strongly about. Was there a particular patient or an experience that made you realise that continuity was something that you really wanted to focus on as part of your career?
So I finished my GP training in the Northeast in 2013. I went into a partnership at Whitley Bay, where I am now, and we've run personal lists forever. They've never stopped doing them. So there's always been a lot of misunderstanding about it, and we've always found it really enjoyable, and we found it to be more efficient. So I've been writing about it for about 12 years, about how it's good. I guess more recently there's been a lot more evidence for this. So it's gone from being a nice, maybe nostalgic idea to actually an evidence-based approach, which effectively, if you know your doctor longer and you see them regularly, you might live longer, which is quite a massive intervention. The other thing that, sort of on a personal note, it's a more enjoyable job because you see the outcomes of your practice. So you see the good things, you see the things that haven't gone so well, and you reflect on those. But also my own health benefited from having patients that know me. During the pandemic, obviously, you didn't see patients as often. And in 2021, I had a day where two patients came in and they both said, "Oh, how are you, doctor?" "Oh, fine, yeah." And they said, "You're looking a bit thinner." And I thought, this is a bit of an odd thing. They said, "Oh, you've been running more." And I thought, actually, I haven't been running more because I've hurt my foot. So then this stayed with me all day. And I thought, obviously losing a bit of weight. So I contacted my own GP and said, "I'm losing some weight." They ran some tests. Within a week, I was on insulin and basically in hospital, picked up my late onset type 1 diabetes. But what stayed with me was those two patients that separately knew me well enough to know I go running, and also know me well enough to go, "Are you okay, doctor? You obviously lost some weight." But because the weight loss was so insidious, they'd only noticed this because they hadn't seen me for maybe 6 or 9 months over the pandemic. So from a personal point of view, you get that feedback. From my perspective, that was quite critical in getting the right help at the right time.
Yeah, and what about you, Tom? How did you get interested in this particular area of work?
I suppose I kind of reflect on the benefits of continuity, both for patients and for, especially as an early career GP, thinking about how kind of you get these closed loop, almost episodes of care when you have continuity, in that you follow up the patients that you make a plan for, you get to receive your own letters, your own test results, and you experience this kind of closed loop.
You've touched on it a bit, but I mean, I've spoken to other people as well who explain that continuity actually, it makes it a more satisfying job, doesn't it, as being a GP? Why is that?
I was thinking about this. Obviously, I've always worked in this system, so I don't have the comparison. But I chatted to one of our more recent colleagues who was a salaried GP in a large pooled list practice. So that's where any patient sees anybody. and all the results went to different GPs. It was sort of fairly chaotic. And they describe the workload being similar, but a lot more efficient and a lot more familiar. So the patients become familiar. So you're not just signing a prescription, you might realise who that patient is. Well, the job satisfaction just be exponentially greater. And that sense of ownership and the relationships with your patients is just at a different level. So it's not about working harder. It's actually about allowing GPs as expert relational generalists to actually be able to be relational, because it's very hard to practice if every meeting is the first time you meet somebody, because you've got to gather all that data and try and build that trust. And actually, trust only comes after 3 or 5 contacts. So, and you don't have to data gather as much because you know what job they do and you know what their family situation is. Obviously, you'll update that, but it just becomes a lot more efficient, and you know when something's gone well, and that builds that trust as well. And when stuff hasn't gone well, which happens to any GP, people are a lot more forgiving. They'll forgive the minor mistakes more because as a GP, we'll phone them up and say, I'm very sorry, this is not what I expected to happen. And most of the time, that's really useful.
Government policy in recent years has almost focused universally on access. How has that impacted on continuity, do you think?
I think in practical terms, actually having a really kind of singular emphasis on access, things like same-day appointments and extended hours, clinics, things like that, often is in conflict. It's in opposition really with relational continuity. Patient service over the last sort of 20 years have shown certainly perceptions of access have deteriorated. The frequency of having and getting to see your preferred clinician has, on average, deteriorated. But we've found through this work that there's lots of examples all over the northeast and North Cumbria where we work with practices who have carried on managing to deliver continuity all in their own way. Some of them, like Luke's practice, with personal lists, but actually some of them using different care models where perhaps the acute on the day appointments are still handled by a different care team or paramedics, A&Ps, whereas some of the more chronic and review appointments are held by general practitioners.
Because it's about how you balance continuity and access, and where practices can do that and do that successfully, how do they do it? How does it work?
Tends to work with giving the team or GP. So systems that work well have a population-based approach to continuity. So they'll either have micro teams or a kind of personal list or list-based system. If that micro team or GP is also responsible for access, they will work really hard at making that happen well. So this means that GPs will balance when people come back. So they'll try and spread that out a bit so there's space for new patients to come in. They'll also know people well, so they can sometimes manage things more safely remotely. You might do if you didn't know people well. But it also gives you a different perspective because you're not just looking after the patients on your list that are seeing you that surgery. You're also responsible for the patients that aren't in the surgery as well. So you have an incentive to think about them as well and think about their chronic diseases, think about all those important things that we as GPs do that aren't just seeing patients. People always say if you get better continuity, access will obviously suffer. The evidence is actually the reverse. So somebody did a study on about 10 million GP consultations and realised when continuity was higher, people would wait 18% longer to come back. So if you're thinking about weeks, that's instead of coming back at 4 weeks, they come back at 6 weeks. And that actually reduces demand because they trust the GP more. So they're more likely to follow their advice on medications. They're more likely to self-care in terms of stop smoking and upping their exercise and things. They trust the advice. So that's a benefit as well. We've measured continuity for about 7 or 8 years now, and we look at our annualized consultation rates. How often do the patients attend the practice? And actually, we're about 1.8. That's a lot lower than the national average, which is anywhere between 4 and 6. So as patients know us better, they come less because they trust us more, which therefore gives more space for them to get an appointment. They also know, this is what I often say to patients, if you really struggle to get an appointment, speak to reception and let them know that you need an appointment and we will work something out. We might squeeze them in, we might quickly phone them, but because we know them, we'll be able to do that. I think in a system where you don't have that space, you cannot do that. So it's about getting that understanding that it's not continuity or access. It's actually thinking if you build the continuity, the access will improve. There's a great paper in the BJGP by Professor Tom Marshall that really succinctly summarises that. And that's what any policymaker should read when they're grappling that question, because it's evidence-based, it's quite diagrammatic, and it just shows you how it actually works.
You mentioned the RCGP conference there. There was a really good session with Rowena Christmas, who's the chair of RCGP Wales, and Penny Morland, who'd written a book that was kind of based on her. And they were talking about the fact that continuity is a really precious thing, and it's something that could be lost. And part of the reason it could be lost is because patients don't understand how important it is. And if you've never had it, you don't know how valuable it is. And if all you're being told every day, this is what they were saying on the stage, if all you're being told every day is that you must be able to get an appointment as quickly as possible, that's what the public as large ends up thinking is important. So do you think politicians really understand how important continuity is? And if not, how can we make them understand?
Yeah, so I think it was Patrick Birch did a really good paper in the BJGP that's coming out, I think, in a couple of weeks. But they interviewed GPs and the public and found actually most GPs have never experienced continuity professionally, and most patients haven't experienced it. In the GP patient survey, when you drill down to it, only 12% of patients nationally have a named GP that they see most of the time, and that's down from about 40% in 2014. So that's a massive drop-off. But what it comes down to is what you really think general practice is. If we think it's A&E light or a kind of advanced walk-in centre for transactional care where every episode of care is different and we make it into a task, that's one view. Or do you think actually it's relational generalism that has longitudinal care effectively from cradle to grave? Obviously, people move around and people have transient populations, and you can't achieve that. But that's what the Royal College of GPs have in their syllabus. That's what they're aiming for, is to generate relational generalists. So if we actually believe that, that's what we need to be aiming for. But to answer your question, I'm not sure politicians do get that. I think they think we're kind of A&E light or transactional care. What they need to realise is actually relational generalism is both safer, better, and crucially for them, more cost effective. The Royal College of GPs, somebody presented a great poster on 2-week wait referrals and found actually they're more accurate if the patients see their regular doctor. There's a paper last year from Scotland that looked at haematological cancers and found patients knowing their GP was associated with a reduced delay in referral, so they referred faster and more promptly. General practice is hard. It's subtle signs that make the difference. I've had a few patients in the last few weeks where it's been a subtlety that's made me think there's something really wrong. All their numbers, all their scores have been normal, but there's been something that's jumped out that said something is different. They're not quite right. We've held on to that. We've referred them to hospital and thankfully recovered, but it could have been missed in another system where we didn't know the baseline. We didn't know that was not their norm. I think it's getting politicians to actually believe it's possible and believe the value in it. And that's some of what mine and Tom's work has been, sharing that both as a regional level, but also there's been some national conversations about continuity that we've been involved in as well.
Tom, I noticed you've been involved in developing training resources for GP registrars as well in your area. What did that involve, and how do you think we need to incorporate sort of continuity into GP training? Because if, as Luke says, there are lots of GPs don't experience it, surely it's very important to get GPs at the start of their careers to buy into this way of working.
So I think the statistics show that there's something like about 10% of practices, or maybe even less in England, run personal list systems. So that's obviously only one way of delivering continuity for patients, but it's probably the most kind of pure and kind of easiest to understand way. And so it's entirely possible that GP trainees won't rotate through a practice that prioritises continuity in that way, or possibly in any way throughout their training. And I think often the nature of the way that GP resident doctors are deployed through training is often using some of that, being asked to meet some of that on the day demand as well, which again kind of takes a step away from continuity. We produce some resources for our local GP training scheme, really a session around what are the different models of care, what are the different ways of measuring continuity, and what are the different ways of kind of taking steps towards continuity that could be practically applied. So trying to be as pragmatic as possible about it. It's been received well. I think it's a useful opportunity in terms of GP training. It's a perfect candidate really for an audit or a sort of quality improvement project in practice, to think about what are our levels of continuity now, what small tweaks could we make and see a change in a relatively short period of time. And that really helps to kind of engage with the core concepts of general practice and some of the management of a business side of things as well, and think about what's the ultimate impact on demand and resources when you do that.
Yeah, that's a really good idea, a quality improvement project for registrars. Luke, you've touched on it a bit about receptions, because obviously continuity is not just about the GP, is it? It's about the whole practice team. You have to get everybody on board with this way of working. How important are kind of reception and admin staff, and what do they need to do as part of this?
Yeah, so our receptionists and admin staff are key to continuity, and they're key to, well, the patient experience, aren't they? If the receptionist is friendly and helpful, which they are here, they're really good, you'll see a massive benefit because it takes the temperature down. People don't come in stressed and they don't come in angry. They come in having had a good experience. And that makes a massive difference. When patients register at our practice, the receptionist will chat to them about continuity. So they'll say, we run a different system. You'll generally see your same doctor when the doctor's in. So if they're not in, there's a different conversation. They'll explain which days those GPs work and which would be a best fit for them to join that GP's list. You know, if the one day that they can come to the practice is a Thursday, they'll need a GP that works a Thursday. That's key because that really says to the patient, this is your doctor. The patients then know who their doctor is. When they phone up for an appointment, or if they come in, or they do an e-consult, or they contact us in a myriad of different ways, they will be asked, who is your doctor? That's the key question. Then they'll work out when they can be seen, they'll work out what can be done, whether it needs to be a phone call or a face-to-face. So they're key to that process. And that's the patient-facing side. They're also key to the back office process because the reception and admin team will also know which doctor it is to ask about which patient. So the other question we always hear in the back office is, who is the doctor? And that really means who is responsible. And that stops that kind of nobody quite wanting to pick up the difficult issue, because when it's your patient, it's your issue. And actually that means that we don't spend energy negotiating that. We just get on with it more. And that helps in terms of management of the practice and also supports receptionists. They're not trying to pick which GP they should ask that day. They just go to the named doctor. That smooths that out and makes it much easier. So hopefully they feel better supported from that as well.
If someone phoned up and they had what they perceived to be an urgent problem, they would have the option of seeing someone else if they wanted a quicker appointment. Is that how it works? Do they get that choice?
Each day we run 50% of our appointments as pre-bookable and 50% as urgent. And the urgent appointments will be booked in via reception based on what the patient says. It would go to another clinician. It would come to us. If the patient still felt it was urgent, it would be something that we would maybe add on or negotiate with them or say, oh yeah, you can open up a slot in a day or two's time to fit those in. We do have a GP trainee. If they're not full with the trainer's patients, then they will see other people's patients to kind of give them that experience. And we also more recently have got a salaried doctor that basically covers everybody's holiday. So she's like we used to have locums, but she's a much better resource for that because she followed people up a bit. So there are other options, but most people will be directed to see their named doctor. People always ask what happens when you're on leave. In the practice, we provide 50% of the normal appointments spread amongst the other doctors in the practice. So we cover each other's leave. In those appointments, we'll deal with the acute issues that can't wait until that clinician comes back. We'll try not to get involved in chronic ongoing issues. What we're trying to do is give people that continuity for the ongoing things, but deal with the acute things during people's periods of leave so that that patient need is still met, but the chronic issues would pass back to their regular named doctor.
You're obviously working on this project across North Tyneside around continuity. You've also been involved in pilots around continuity and integrated care. What are those actually looking at?
That comes back to one of the real fundamental concepts around continuity we've both encountered, which is that you basically have to count. Continuity as a concept is quite tricky to measure compared to other kind of forms of activity. It's not intuitive, it's not built into lots of patient record systems. And so one of the major things we've been doing in the practice pilots is basically supporting 3 practices in particular, but also kind of wider group of practices in the area to look at their own data to understand kind of what are the demographic makeups of their practice, but also how do they consult differently. And so we've gone from a place of having about 1 in 20 patients that we know of in the patch having a measurable measure of continuity of care where we're trying to target continuity towards them, to about 1 in 4 now. So lots and lots of work still to do, but quite a big increase in our awareness of kind of who is getting some continuity-based care. Those have all had slightly different approaches. One of the practices was aiming to go from a sort of near personal list system to a real kind of wholesale personal list adoption, and so getting much closer to a sort of traditional model of continuity of care. And some were more looking into kind of site-specific micro teams where the practice is split over several different sites, lots of patients in general, but could be well served by kind of concentrated hubs almost, where you create a team within the wider primary care team and have continuity delivered that way. The project's really gone from initially a kind of awareness raising initiative where we kind of presented at local time out and protected learning time events into trying to develop some tools as a system that enable practices to do these calculations themselves, and with some support from us to try to calculate what is your level of continuity and how consistently do patients get to consult with the same clinicians, so that you can then see what the knock-on impact is on demand and in the quality of care that they receive.
Are there other ways of measuring continuity? What is the best way of doing it?
The simplest, most accessible way is to have a look at the GP patient survey results. So there is a measure there. How often do you consult with your preferred clinician of choice? And so that's readily available. Anyone in the country can pop their GP surgery in and get the answer to that and see what the graph looks like over the last 10 years without doing any more kind of effort. And there's some recent published study data that basically shows that correlates pretty well with the formal measures of continuity of care as well. So really, really good starting place and probably a good conversation starter in practices who want to kind of raise the issue for the first time. The more formal ways of assessing continuity of care are a little bit more labour intensive, but we've been working to try to make it easier to do that. And there's various teams that are trying to embed it in patient record systems as well. So the most common mechanism used is the usual provider of care. So that basically measures what proportion of consultations are held with the clinician that a patient sees most often. So if you just take all of the patients that have consulted more than about 2 or 3 times in the last, say, 12 months, and you look at how often did they consult with the person that they saw most frequently. So you don't need to have patients grouped to lists. It doesn't matter what their designated GP is. It's just who do they see most frequently and how consistently do they see them. So that's fairly straightforward to calculate. And we've been working to produce a kind of toolkit locally that helps to ease the process of calculating that. There's also the St Leonard's Index of Continuity of Care. That's kind of the second most common one that's out there. And what's great about it is that you can use it even if you haven't had 2 or 3 consultations, but it does rely on having a meaningful nominated GP already. So this is suitable for practices that have already got patients in lists with a GP's name almost against that list, so that you can say what proportion of all the consultations take place with the patient's named GP.
The government's always talking, I hear it so many times, it's almost become on repeat, bringing back the family doctor. But basically, when you actually start looking at some of the documents and things that are coming out from NHS England and the government about it, they often talk about continuity of care for patients who would benefit from it the most. So certain cohorts of patients, people with multiple long-term conditions, people who are frail. Is it important to deliver continuity of care for all patients, or should practices just be focusing on certain cohorts of patients? What do you think about that?
So the evidence for continuity in terms of mortality benefit and the big Norway studies that have shown colossal benefits to the country in reduced healthcare costs are population. So they're not necessarily targeting it, because if you target it, you're making an assumption about who will benefit the most and you're picking out different people. So frailty is an obvious one you start with, or palliative care, and I think most GPs do that quite well anyway. If you target it, obviously there'll be people that miss it, so people that just miss out on it, and they will do worse than they might have done anyway. The risk of targeting it is that you have an active process that you spend a lot of energy on trying to find the people that will benefit the most. And that can take clinicians away from actually seeing patients, and it can take funding away from actually core NHS work. The ideal approach is that you'd have some population base, whether it's team or list, and you just give it to everybody, and those that need it most will benefit the most. So that's using the principle of proportional universalism that Marmot introduced, which is basically you give it to everybody, but those with the greatest health needs or the greatest health inequalities, you'd actually give them some support. So you might introduce it quietly for your whole practice. We've had practices that have moved from pooled list to personal list systems. You would introduce that, but then each cohort you'd promote it to. So you might use your QOF cohort. So you might use your severe mental health cohort. You might use your frailty index patients as a starting point. But it's thinking, actually, there's patients that need continuity that will be missed out if we target it. So the most recent case is the case of Jess Brady that was in the news, which we've got Jess's rule, which is a great rule. There was 20 contacts in 5 months to her practice from her. She was a healthy 27-year-old at the start of the journey. You need somebody that can pick up that a 27-year-old is contacting the practice weekly, at least between 3 and 5 contacts, not leaving it for 20. When we chat to practices that have had a team-based approaches, they have a care coordinator. So they have somebody that is in the admin team that helps with that team approach. So they could be like, well, why does this 27-year-old keep needing an appointment? Maybe they should just see this person within the team. Because if she'd seen 1 or 2 GPs rather than 4 or 5, I think the outcome would have been faster. And her mum has mentioned that on TV programs and on the news and different things, that they wish that could have been possible. And actually, I think if we target it to certain groups, maybe that would only be a small percentage of the population. We need to make it more normal. Continuity needs to be a default setting rather than just exceptional. So that's a big national debate going on about what we do. And certainly Wales at the RCGP conference were talking about their process, and they are starting with a targeted approach. But the ambition is to make, within 5 years, continuity more normal in Wales. So it becomes an expectation that patients will see their doctor unless they're on holiday or there's difficulty in accessing them. But I think it's trying to make it more universal. And obviously, as taxpayers, people want a service that's universal. So bringing back the family docs will only happen, patients will only see it, and voters will only see it if it happens for most people. If you target it, it'll be something that isn't really seen or heard. We talk about the value of identifying emerging themes with patients. We get lots of information to us as clinicians, and that helps us spot emerging themes, like the child that's going to A&E a lot, or the patient that keeps going to urgent care that actually needs to come to primary care, and then kind of doing something active about that. But we need to, as clinicians, have that information fed to us in a better way so we can pick up those emerging themes. And it's also, as Tom's alluded to, it helps us educationally. So you learn more as a clinician. If you get your feedback, you'll go, okay, that was a pneumonia or that was a pneumothorax. It's really hard to follow stuff up if you don't have that system. You have to effectively set yourself lots of reminders. Whereas a system where that information flows bound, it really values the expert generalism that we train people for.
How does continuity fit into a neighbourhood NHS? Obviously, we're moving towards this new world of integrated care, neighbourhoods. How important will continuity be in that, and how can you make sure it's preserved in these new ways of working?
Well, think about continuity for policy. Over the last 40 years, there's been 400 different access policies put in place. I wouldn't say they've failed, but they haven't worked that well, because we've got 40% more appointments being delivered, but patients are a lot less happy. Evidence base for continuity is much stronger than a lot of these access reviews. We need to think that policy actually over the last 20 and certainly 40 years has made continuity harder to do. And certainly some practices have said, we've had enough, we're not doing this anymore, it's too difficult because there's so many policies that come against it. So if we're going to put it in the neighbourhood NHS, we need to actually value it and think about it as a core principle. It shouldn't be a nice add-on that we add if we've got time, or if we've got capacity, we'll do a bit of continuity. We need to think, let's value it at the start and design it into the system and design policies that help it. Whereas what happens generally in policies, people do lots of disparate policies that seem good on paper, but actually don't make being a family doctor any easier. They make it harder. So I think I would say, if you're going to design it into the neighbourhood NHS, think about it and design it in, and actually look at the evidence. Don't try and think, what do patients want? What do they actually want? And they actually want to be known, and they want a clinician that they trust and knows them, and a health system that will give them timely access. So that's all achievable. We just need to have a focus that actually happens.
And I suppose it's partly about kind of trying to hold two things in mind, which is we've got this big body of evidence that gives you that overall picture of having really good relational continuity reduces probably all-cause mortality, has lots of knock-on impact in terms of how long patients are prepared to wait for appointments, how likely they are to generate a complaint if something goes wrong, all of the things that kind of stem from that. but also that we've got this emergent body of evidence that says you can do it in lots of different ways, and you can focus on episodic continuity as well and have really good continuity within a singular episode of care. And having a named list system isn't the only way to do it, basically. And so if we think about kind of scaling up or delivering healthcare interventions at a sort of neighbourhood level, it doesn't have to be in contrast to that. It's I think thinking about how do we make sure that it doesn't adversely affect the continuity we've already got, and how do we kind of protect that and champion that where we can, but also how do we try to build it into new systems as we're designing them.
Information sharing is obviously going to be really important, isn't it, in all of this?
Exactly. So, for example, clinicians receiving their own test results, or a good flow of information from secondary to primary care. And so, if we're introducing kind of new layers and new providers, I guess, in the wider consultant picture, then making sure that information flows really neatly between those is one of the ways that we can protect continuity in the system.
Tom's talked about episodic continuity, and there's things like micro teams that feel really well into actually neighbourhood working. So they're teams that, you get a population and you put clinicians in teams of 2 or 3 that cover a week, and that works really, really well for lots of practices. There was a practice that presented at the Royal College of GPs conference as well in Southampton that went from 3% continuity to 35% continuity. That's the usual provider of care index within 12 months. And they talk about the benefits to the patients and the benefits to the clinicians and the wider staff, but also they've now got a problem of more patients wanting to join. So they're having to expand their clinical teams because actually it's made such a difference. So it's not one solution, it's finding different solutions that work for different teams. And micro teams is a really good solution that fits in with a neighbourhood NHS as well. I think it's thinking it's achievable, it's not difficult to do, and it's possible. So they're all the things and all the barriers that people come up against for continuity. There's loads of examples of practices doing it. So people go, you can't do it with part-time GPs. Well, actually, loads of practices do it with part-time GPs. It's possible. It's just really thinking about it and building it in.
If there's a GP partner, a practice manager listening to this and they think, right, we've really got to start doing continuity in our practice. We've wanted to do it for ages. This has inspired me to get going in it. What is the one thing they could really focus on tomorrow if they wanted to get started?
I would say do what you know best, which is kind of apply that diagnostic process. Do some data gathering. There's loads and loads of resources already out there. There's a Continuity Counts website, which is run by the team at St Leonard's in Exeter. Got lots and lots of information about how to measure, how to implement continuity of care modules. We've put together a BMJ learning module as well, which hopefully will go live any day now, so people can kind of read up a bit more about that and engage with the ideas a bit more. Do your examination. So look at the patient survey results if that's the easiest thing to do, or have a think about measuring the data in your own practice and make a diagnosis really. So have a chat with your team, maybe an informal chat or a practice meeting, start a conversation about where you are on the kind of continuity spectrum and what things you might be able to do to progress it forwards.
Think it's possible, look at the evidence summaries, and then start to talk about it as a practice team, because actually there will be frustrations in there. There'll be people going, well, I get results, I don't know what to do with them. And then it's thinking, if we have a system where the results go back to the clinician that ordered them, that will make people's lives easier. The cognitive load is less. But then also making, I was chatting to a practice earlier who have made booking in follow-up easier to think, okay, I need to see you again in 6 weeks. Here's an appointment, rather than that person having to phone up again in 6 weeks, get through the triage system and hope they can see you. It's just making it possible. It's practices thinking about it and thinking about what they can do now, and then revisiting that again in a couple of months and thinking about, has that helped? What can we learn from that?
That was brilliant. Thank you both for coming on the podcast today.
Oh, thanks for having us.
Thank you. That's been brilliant. Thanks.
Well, that's it for this week. Thanks so much to Luke and Tom, and thank you for listening. You can find links to some of the resources they mentioned in the notes for this episode. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.